on and able to listen to the presentation. I want to thank you all for joining us today. I don't know if you heard that little announcement from the voice, but you all are on mute, so you won't be able to ask any questions out loud, but there is a question box. You should have a little box up on your screen when you log on to the webinar site where you can ask questions. Dr. Groh will be answering those questions at the end of the session, so as you're thinking about them or whatever, go ahead and continue to type them into the question box. Any questions that he doesn't get to at the end, he will answer afterwards, and then we'll send out the answers to everybody following the webinar, shortly after the webinar. So just a couple more minutes, and then we'll get started. I don't know if some of you saw, but you can also use the chat feature. I just sent everybody a message just seeing if you guys can see the presentation. So if somebody can just maybe type in their yes or no, or anybody? Oh, good. Thank you. All right, we're going to go ahead and get started. We try to keep these to an hour. So I'm going to just introduce Dr. Grill to you. Dr. Grill is an ER physician. He also has a child with Angelman syndrome. He's on our board of directors and has presented at our last conference in Orlando. So with that, go ahead, Dr. Grill.
All right, good afternoon to everybody who's here. I appreciate your time. This will be my first time doing a lecture on this GoToWebinar platform, so hopefully I'm not too boring with this. But today we're going to talk about some emergency medical considerations, hopefully at least somewhat specific to our population of Angelman syndrome. A little bit about myself. I went to a small private college in Grand Rapids called Kelvin. I went to Michigan State for medical school, and despite the fact that we lost in the Elite Eight, it was still a good basketball season for us. I did my residency training in emergency medicine in Metro Detroit, which is a great place to learn emergency medicine, and now practice along the shores of Lake Michigan. So people hear a lot of bad things about the state of Michigan in the news, but the area that I live in has been named the happiest place in the country to live. Good Morning America says that our lake shore and the Sleeping Bear Dunes are the most beautiful place in the United States. So we'd be happy to have you come and visit, and if you do, let me know, because my wife and I would love to get together with you. So this is my interest in Angelman syndrome. Probably without this, as my son Noah, he's just turned 5, and without him, probably would not know nearly what I know right now about Angelman syndrome. Would have been something I just remember hearing about in my pediatrics course. But this is what got me involved with Angelman syndrome, and he makes, obviously, my life quite happy. So that's my interest in it. So an overview of what we'll talk about today, and I'll try to go through this relatively quickly so that we have time at the end, because when I gave this lecture at the conference, there were quite a few questions, and I'll try to get through all of them. We'll go over just some general considerations when we think about the emergency department, and then we'll talk briefly about some things that are specific to Angelman syndrome, obviously being seizures, some environmental considerations, gastrointestinal problems. We'll talk a little bit about trauma, specifically head injury, briefly about toxicology, and some general things about fevers. I want you to feel free to ask any questions that you might have, and like Sheila said, we'll get to those at the end, and if we don't have time, I will email them out. I actually worked till 1 a.m. last night. I had a meeting at 7 a.m. this morning and have the rest of the day off, so I can actually stay on here for as long as people want to answer questions. One quick disclaimer, this lecture obviously can't provide any specific medical advice. Probably most of you I've not met before. So obviously if you have any specific questions, the best place to get that is with your physician, but I'm happy to answer any general questions that you might have. So we'll start with just some general considerations about the emergency department. This is unfortunately becoming all too realistic as our volumes in the ER get higher and higher, which is becoming an increasing problem. Hopefully none of you experience anything like this, but unfortunately it does happen pretty much every day across the country. So we'll talk first about ER doctors. It is absolutely true that we deal with emergencies daily. The way that I started my day yesterday was with a 40-something-year-old individual who had sudden cardiac arrest while working out at a local Planet Fitness. I had a ruptured aortic aneurysm for my second patient. My third was an elderly lady with a pulse rate almost 200. So we deal with critical things on a daily basis. There are some populations that are distinct challenges. Oftentimes the pediatric population falls into one of those because on average most ERs see less than 25% of our patients are children, and so when you don't do as much of it, it becomes a little more challenging. And of course special needs individuals would fall into a category, and so many of us have both a child and an individual has special needs. Some of them obviously are adults. And so that can provide a little bit of difficulty simply because we don't see a whole lot of that. Maybe even more importantly, when we talk about the ER nurses, I try to remind people that you really do catch more bees with honey. The important part about this case is that that means you're going to get more bedside care time. And as I noted here, yes, our primary job is to be an advocate for our loved ones with Angelman syndrome. It's the way that you go about it that's critically important. And I see this quite frequently where people come in and their immediate disposition is confrontational or adversarial, probably because many of us are used to having to be that way in order to get what we want or what our individuals need. The nurses probably have 1 or 2 or 3 patients, depending on the acuity of them, and they can choose which room they spend their time in or if they're doing computer work. And obviously, if it's a less than pleasant room for them to be in, they're not going to spend as much time in there. And conversely, if it's a really enjoyable room to be in, they're going to spend more time in there. Most of you probably recognize from having been in the ER before that usually the ER doctor's in for about 5 minutes. He might stop in or she might stop in at one point during the middle of your stay, and then at the very end to tell you what the results are and whether you're going to need admission or discharge. And so we really rely heavily on the nurses to monitor patients in the ER to notice subtle changes. And it's really important to get on your nurse's good side because you can have a dramatically different stay in the ER, both your quality of care as well as your satisfaction, based on how the nurses feel and how much time they spend at the bedside. And so while being an advocate, I would just suggest that maybe you go about it in a manner that would be pleasing to individuals. I tell people that, yeah, you're paying to be in the ER. It's kind of a unique environment to be in. But the ER doctors and the nurses are human beings too, and they appreciate a level of courtesy just like anybody else would. Another thing that we hear a lot of complaints about in the ER is the amount of time that they spend in the ER, which I can tell you from personal experience, every ER across the country is trying to reduce the amount of time that people spend in the ER, and that's for a multitude of reasons. Number one is that's a national metric, the amount of time door to discharge or door to admission, and the hospitals, and increasingly so even the ER physicians, are paid based on that. And so they really do try to expedite stays in the emergency department. The other issue is oftentimes kids are very enjoyable having the ER, but they're very high energy. And because of that, as this cartoon says, we'll try to get you out of here quickly because we need the rest, and that can absolutely be true in a busy emergency department. So rare syndromes in particular are a little bit difficult, even more so than less rare syndromes, simply because we don't know about them as physicians, especially for the majority of us that live near community ERs and not tertiary medical centers. And so what I tell a lot of people who I meet with Angelman syndrome is you really need to be an expert in Angelman syndrome, because more than likely you're going to know more about it than your doctor. You're probably going to know more about it than your pediatrician. You're certainly going to know more about it than your average ER doctor. And that can be very, very beneficial in your communication with any medical establishment, particularly in the ER, if you have some degree of expertise in Angelman syndrome. Now, I'm not saying that you need to have a level of knowledge that would be equivalent to an ER doctor for treating emergency medicine, emergency problems. That's obviously what we do for a living. But specific to Angelman syndrome, you're going to have a lot of information. Even more importantly, you're going to be an expert on your loved one that has Angelman syndrome, and that can provide a pretty good benefit to us on an emergent basis. One interesting thing is if you're fortunate enough to live near a children's hospital, I would suggest that you use it. Some children's hospitals cut people off at 18 years old, and after that point, you go to standard adult physicians. Ours, for instance, the nearest one to where I live would be Grand Rapids, and most of the pediatric specialists follow people well into adulthood who have rare genetic syndrome, simply because the truth of the matter is most adult physicians don't know a whole lot about these because they really don't see them that frequently. And so many children's hospitals are not just for children. And if you do happen to live near one, probably most of your community ERs send all of their sick kids to that children's hospital. So I can tell you, despite the fact that I work in a community ER, and that's where I make my living and support my family, when no one needs to use the ER, we typically do go to children's hospital simply because that's where they have the level of expertise that's necessary to deal with all the complications that arise as a result of Angelman syndrome. Another really important thing is if you can possibly bring an accurate and updated list of all the medical problems, surgeries, and medications. The link that you see on your screen right now is from the American Academy of Pediatrics in conjunction with my specialty college, which is the American College of Emergency Physicians, created this form not for special needs population, just for children or individuals in general. I oftentimes hear people come in and we ask them about their medical history. They say, well, you should have it in your computer, and that's probably true. If you've been there before, we are going to have it in the computer. That means I get to spend that 5 minutes in front of a computer screen rather than that 5 minutes in the room with the patient. And so if you can hand something to me and to the nurse that has everything spelled out line for line, that means I don't have to look it up in the computer. That means when I dictate, I can rattle that off really quickly, which just frees me up for more clinical care time. My own bias being my time is better spent in the room rather than in front of a computer. And this is something that really expedites that. If you have a fairly straightforward individual with Angelman syndrome, like my son, for instance, his only diagnosis is Angelman syndrome, his only medication is Keppra, he's never had any surgeries, that's pretty easy, that's pretty straightforward. It takes me all about 5 seconds to say to somebody. And so that's reasonable if that's what you have, not to have one of these, but many of us have kids with really complicated medical histories with medications. They're adjusted frequently. They have narrow therapeutic windows, things like that. This is a really beneficial form to have. And you don't have to use this particular one. If you look online, you'll find multiple forms of this. Even if you just write it on a white piece of paper and bring it in with this information on it, that's perfectly reasonable. It helps us out really a lot. And like I said, it frees us up to spend more time at the bedside, which is the most important thing. So our next subject, probably all of you with Angelman syndrome can relate to this. As you can see, Noah does not appreciate getting his EEGs for his monitoring of his seizures. There are going to be quite a few lectures on this webinar series. I know we've already had one on seizures, and most of those are going to be given by people who that's what they do. They are neurologists who specialize in seizures. So I'm not going to go into a whole lot of detail about this, simply because there are people who are experts who can provide you with a lot more detail. But we'll talk just generally about this. I know there's usually a lot of questions, and so if they are, feel free to text those in to Sheila, and we'll get to them at the end. And unfortunately, a lot of us are mini epileptologists. In fact, most of our children or individuals with Angelman syndrome are going to have seizures to varying degrees. And so what I tell people when I give this lecture is, if you know it works for your individual with Angelman syndrome and you're a pro at this, change nothing based on what I'm going to say. This is really more directed for people who are newly diagnosed or people who maybe aren't well controlled or don't have a whole significant frequency of seizures, and so they're not as up to date, or I guess used to taking care of their individual with seizures when they occur. So one of the main questions is, what is an emergent seizure? When do I need to go to the ER? And this isn't always clear for people. Some of it's because no one ever takes the time to explain it to them. but generally a seizure lasting longer than 5 minutes is something that we want to see in the ER. If you have a seizure that lasts 30 seconds, it goes away, you don't have any treatment for it, that's probably something that's perfectly reasonable to stay at home. Likewise, if you're used to this and you have an individual who quite frequently sees this for 20 minutes, you might be perfectly comfortable dealing with that at home, and that's fine. But for the rest of us who don't experience things like this, seizures in general lasting longer than 5 minutes are problematic, and we like to see those in the ER. Another one is if you're traveling, and I oftentimes have questions of why on earth, if we're traveling, would that be something we should go to the ER for? And really the answer is, you know, if you're traveling, let's say you're in Chicago or St. Louis or someplace and you live in California, you have no idea where the nearest children's hospital is going to be or the nearest hospital is going to be or what anyone's going to be able to do as far as seizure management. And so it just increases the risk to the individual who's having the seizure, and so we suggest getting to the ER sooner rather than later in those cases. If you live in an area that has a long transport time to the hospital, and let's say you live way out in the sticks somewhere and you've got a 30 or 45-minute drive time or ambulance ride to the hospital, you might not want to even wait the 5 minutes simply because you know it's going to be a long trip anyway, and the sooner you get to care, the better. Back-to-back seizures in medicine, we call it status epilepticus. That's when somebody seizes. They come out of a seizure, but they're never back to normal. Then they seize again, then they seize again, then they seize again. That's really problematic. That's just like having a seizure longer than 5 minutes. If that occurs, that is always an indication to come to the ER. When a seizure is associated with trauma, we usually suggest you come in simply because even if we don't need to evaluate anything in regards to the seizure, you need evaluation in regards to the trauma. And so they're standing, they seize, they fall, they hit their head, they hurt their wrist or their ankle. That certainly is a reason to come into the ER. The last one is fairly important, and that's just if there's something different about it. If you say, you know what, my kid has seized probably 10,000 times in the last 10 years, but this is different. There's something different about it. There's something that's concerning me. We call that in medicine a gestalt. That's really important, and actually the medical evidence kind of bears this out for multiple different types of situations where just the overall impression of a parent or a physician or a nurse oftentimes is just as good as a quote-unquote validated system that we use in medicine. And so if you're concerned about something or something's different, that's a perfectly reasonable reason to come into the ER for evaluation. So rescue treatment for seizures, there are a lot of them, and we certainly can't go over all of them here. I'll talk about some of the more common ones here. One that many of you are probably going to be familiar with is Diastat. That's a rectal gel that you give an individual who is seizing, usually if it's lasting longer than 5 minutes. Advent is probably another one that many of you have heard of. For your purposes at home, this is going to be an oral medication, and actually we use this. We have Diastat. We never had to use it with Noel, but we have Advent at home. He tends to seize with a stomach flu, and what we found is if you give him Zofran for the nausea and we give him Ativan, it really prevents him from seizing in the first place. We've had a tremendous amount of success with that just as a preventative measure for seizures. Versed is another one. You're probably not going to have that in the home, but you might if you ever have a paramedic come to your house and they need to give something right away. You might see them give Versed. It's kind of like Ativan, same overall class of medications, but it can be given orally, nasally. It can be given IV, and it can be given as a shot into the muscle, so multiple different ways of delivery for Versed. Sometimes you just give an extra dose of the seizure medicine. This is not one that I would ever suggest that you use without consultation first with your neurologist, simply because some seizure medicines have a very narrow therapeutic window, and so I wouldn't want someone getting toxic because you gave an extra dose of a seizure medicine, but sometimes it's perfectly appropriate and useful. What we usually say is if you're new to this and you have to give a rescue medication, you should go to the ER for observation, particularly if you're using something like Diastat or Ativan, or if you end up using Versed, somehow you got a hold of that at home, simply because all of those have some degree of respiratory depression, which means it decreases the drive to breathe, usually not to any significant degree, but enough so that if it's the first time, we like to monitor that individual in the ER for a period of time before we send you home just to make sure, you know, better safe than sorry. And so you should always, if this is your first time or you're just new at this, always come to the ER for observation if you have to give a rescue medication. Oftentimes, like I said, if you're an old pro at this, it's perfectly reasonable to monitor at home. I've talked to people who've given Diastat literally dozens of times, and there's no reason that every single time you have to go to the ER. But like I said, if you're new at this, certainly come in for observation. The other interesting thing is, if you're ever not sure, it's perfectly reasonable to call the neurologist first and get their opinion before coming to the ER and just say, hey, here's what's going on, this is what the seizure looked like, this is what we did or didn't have to do. Do you think we should go to the ER? Do we not think we need to go to the ER? And you can discuss that with them. That's a perfectly reasonable approach to this. So probably the most important thing as far as what we're going to discuss in seizures is this slide right here, and that's what to do during a seizure. So if someone's seizing, we like to get them to the lowest possible point possible, which obviously usually is the floor. Sometimes in our population, especially if they're in complicated wheelchairs and things, this may not be possible. That's okay. Really what we're trying to avoid is any sort of trauma or a fall. So if you can get them on the floor while they're seizing, you know they're not going to fall, they're not going to break a bone, have neck or head trauma or anything like that. And we usually suggest in medicine laying them on their left side, laying on the right side is perfectly reasonable. And the reason is simple. Most of you have seen a seizure. You know that oftentimes there's increased oral secretions. There might be vomiting associated with it. And what we really want to prevent is aspiration, because as a result of that, you can get pneumonia and other problems. And so that's really the purpose of lying them on their side. Never place anything in their mouth. We have people frequently come into the ER and say, I put my wallet in the mouth or a stick or my finger or something like that. That's really a bad idea. People choke to death every year in this country based on something that someone stuck in someone's mouth when they're having a seizure. I know everyone gets concerned about they're going to bite their tongue, they're going to bite their lip, and that certainly is a valid concern. But what I try to tell people is I can sew up a lip laceration, we can sew up a tongue laceration, but if they choke to death, I can't fix that. So never ever place anything in their mouth. And then this is one actually that I learned from experience, and that's to look at a watch or a clock when the seizure starts. So when Noah first started having seizures, actually my mom was at her house, and he started to have a seizure, and so I looked at the clock, and I just said, well, we'll watch it, you know, follow the rules I told you about the 5 minutes and everything else. And so I watched him for a while, and I said to my mom, okay, go get the diastat, and I looked at the clock, it had been 45 seconds. So that's an ER doctor who was interpreting 45 seconds to be a whole lot longer than what it was. So it's really beneficial just from that perspective alone to look at a clock, because it gives you an objective read of how much time actually has passed. The other thing that helps is when you get into the ER, it helps me as an ER doctor or as a neurologist to determine a course of action going forward. Like I said, it makes a big difference whether it was a 45-second seizure that doesn't even need to go to the ER like his didn't, or a 7-minute seizure where maybe they're going to want to admit for observation. And so the exact times help, not just for treating with diastat, but for ultimate disposition from the ER as far as what we're going to do as a medical team for that individual based on the length of time of their seizure. So environmental considerations is another specific area that's important to many individuals with Angelman syndrome. And first we'll talk about sunburn. Deletion-positive individuals in particular tend to be prone to hypopigmentation. If you're like my son Noah and you've got a pasty-colored dad, that's an additional risk factor, obviously. Obviously, it's going to be completely dependent on a lot of genetics, whether you're a dark-skinned or light-skinned individual. But like I said, many deletion-positive individuals prone to hypopigmentation as a result of that are more prone to sunburn. Many of them are also very heat intolerant. That increases the risk of things like heat stroke, of heat exhaustion. So we need to be very careful in the sun in general with our individuals. And the best treatment really is to prevent it from ever occurring in the first place. And the American Academy of Dermatology suggests at least an SPF of 30. And one of the important things is this UVA and UVB coverage right here. Oftentimes we'll see people coming to the ER with a sunburn, and where we work here on Lake Michigan Shore, it's a really big tourist area. And they'll actually bring their sunscreen into the ER to prove that they were using it. And oftentimes we'll see it just have, for instance, UVA coverage. It doesn't have any UVB coverage in it, which is probably why they're getting sunburn, because they're not getting complete blocking of all ultraviolet rays from the sun. So you just have to read right on the bottom of it when you buy it in the store, and it will tell you whether it covers one or both. Remembering to reapply it every couple hours, that can be difficult, especially if you're having fun, but do try your best to remember that, particularly if individuals are in and out of the water, because it will wash it off. If you're not swimming, sitting under an umbrella or sitting in the shade is the best thing. I know a lot of people love the sun, especially here in Michigan. We had 2 inches of snow just the other day, and I would love to see the sun in the warm right now, but in general, during the summertime, if you can be in the shade, that's really ideal. Swim shirts are a great idea, and so are hats. If you go to many other countries, you will notice that the use of swim shirts is pretty much, in general, everyone's got one on because the sun tends to be a lot closer than what it is, say, here in Michigan. But even people in climates such as ours would really benefit from swim shirts because that provides essentially complete blockage of the ultraviolet rays from the sun. So if we say we got sunburn, now what are we going to do? So obviously we have communication challenges in our population, and that's going to provide some problems at times. And if it's a mild burn, topical treatments like aloe are perfectly reasonable, and for many mild cases are entirely sufficient. You won't even need to see a doctor, not your family doctor, not an urgent care, certainly not the ER. And it's a reasonable starting point. As far as pain medications are concerned, there's a class of medicines called non-steroidals or NSAIDs. Motrin, Aleve, and naproxen are examples of those. Those tend to be more beneficial in cases like this simply because you have an inflammatory process that's going on with a sunburn, and they have anti-inflammatory effects. Tylenol is great for pain, but has no anti-inflammatory effects, and so you're not actually treating the cause, so to speak, of the pain. So if you're intolerant or your individual is intolerant to NSAIDs, that's fine. Use Tylenol, that's okay. But if they can tolerate the NSAIDs, that would be my first choice, simply because in addition to the pain control, you're getting that anti-inflammatory effect. The next thing is cool compresses. They can help. You don't necessarily have to do a cold bath, but just a cool washcloth with a small area can be really beneficial for local pain control. And then complete sun avoidance. And this is really important because oftentimes we'll see people get sunburned. They'll come inside that night, they'll put aloe on, and then their parents or their caretakers take them right back out in the sun the next day because they're on vacation. And then what I tell people is just like an ankle sprain, if you sprain your ankle the next day, you're not going to go run a marathon on it because you know you're going to re-injure it. You're probably going to injure it worse than the original injury. And sunburn's the exact same way. If you take healing sunburned skin and you put it into the sun, it's going to get worse, and sometimes it's going to get much worse. So complete sun avoidance is pretty important. Good hydration is also important. When we're in residency, we actually have to learn specific formulas and how much fluids we have to give people based on their burns. Sunburns usually aren't that bad that we need to calculate anything, but they're still a burn, and so they require a lot of fluids. So just try to encourage fluids. It will help with healing and everything else in regards to the burn. So then the question is really, when do we need to go to the ER for these burns? Let's say it looks bad and you're thinking, well, do we need the ER? Do we not need the ER? If you see severe blistering, we usually like to see those. We may look at it and say, no, this looks okay, but that's fine. I'd rather that be our decision as medical professionals rather than yours. So if you see blistering, it's severe, bring that individual into the ER. This next one, unfortunately, is kind of vague, a quote-unquote large percentage of total body surface area. And there's really not a specific rule that's in the medical literature as far as this is exactly the amount of body surface area that needs to be burned in order to be seen as far as what's defined as large. In general, it's kind of commonly accepted that if it's a moderate burn, if it's greater than 10% of the body surface area or greater than 5% for severe burn, they need to be seen. And that then begs the question, of course, is, well, how do I estimate the percent of the body surface area that's burned? And the palm of the hand can actually be used. The palm of the hand is 1% of total body surface area. So if you have a child, it's important to know your palm as an adult is not 1% of their body. It's their palm size is what's 1% of their body surface area. So if you get an area about the size of their palm and you look at the burn, that makes a pretty handy tool for estimating about what total body percent surface area has been burned. If it looks infected, we'd like to see that. That, of course, is red. Now, a lot of people are thinking, well, of course it's red. It's a sunburn. That's true. But usually what we call cellulitis or skin infection is a different character. And if you've ever seen it, you kind of know what I'm talking about. But if you're concerned at all, it looks different than it looked the day before. The red seems to be a different character. Bring it in. We'd be happy to take a look at it. Because if it's infected, obviously it needs antibiotics, which the typical sunburn doesn't need. If it's not improving within a couple of days, we'd like to see it. Probably many of you out there have been sunburned or been around individuals who have been sunburned, and you know it hurts really bad when you first get it, but they typically fairly rapidly resolve within a couple of days. And if this sunburn and your individual Angelman syndrome isn't following, that typical progression, then we would like to see it. And then the last reason is the pain's uncontrollable, which sometimes does happen. There might be trouble sleeping. You might be on vacation and just can't get it under control with typical over-the-counter medications, and that is a perfectly reasonable indication to come to the ER. I apologize for my voice. I've got a little bit of a cold today. So here's some pictures from our last couple of family vacations, and there are multiple common themes in here. We'll see if anybody can pick those out. So the first one is a flotation device, which Noah has on in all of these. Another one is a swim shirt, and all the outdoor pictures, you'll see we always keep a swim shirt on, and we do that not just with him, but with our two other typical children as well. The hypopigmentation, like I said, that might be because he's deletion positive. That might also be because his dad is fairly hypopigmented himself. So these are important things, and obviously every vacation we go on involves water. All three of my children love water, probably most of which is Noah. So that's a good segue into talking about water-related concerns, which is a big deal, not just for us in the Angelman syndrome community, but in general, 5,000 people in the United States die of water-related accidents every year. Needless to say, as all of you know, the vast majority of our population does have a unique affinity for water. And because of their unique challenges, both physically and cognitively, we need to be very mindful of water safety issues. Prevention is the key to treatment. You're probably thinking this is becoming kind of a broken record. It's prevention, prevention, prevention. It's not that I'm trying to work myself out of a job, but on the other hand, I kind of am. So constant supervision is really important. I know that sounds obvious, but like I said, I work in a tourist-heavy area, and I can tell you that it's not. The vast majority of water-related injuries or complications that we see in the population are from nobody watching, basically. So do your best. I know it's hard. You turn around, you're grabbing a pop or maybe a snack for your kids or something like that. You turn your back for 1 second. It seems like that's when things always happen. But do your best to have some constant supervision, particularly because we're dealing with a population who has unique needs. Flotation devices are critically important. This long website that I have on here actually is a link that goes to the U.S. Coast Guard. And it's a searchable index where you can look for a whole host of different types of flotation device. If you have a child or an infant, you can actually put that keyword in there, and it will only bring up flotation devices for children or for infants. Excuse me. And this one that you saw, Noah, is called a puddle jumper. Just as a disclaimer, I have no idea if puddle jumper is even a publicly traded company. I'm not invested in them. We happen to find this, and Noah is completely, and so are my other two children, completely independent in the water with it. It's actually U.S. Coast Guard approved, so if you're on a boat and you get stopped by the Coast Guard, which happens frequently around here because we have a Coast Guard station right in town, it counts as a life preserver. So if that's on your child, that counts. You're not going to get a ticket. And they're fantastic. They're relatively inexpensive, $24.99 on the website, but I know they're now selling these at our local stores, and you can get them cheaper than that. So like I said, I don't have any investment in them. It's just personally as a family, we found these things to be really, really useful. If you have an older individual with Angelman syndrome, or you just don't like those puddle jumpers in general, this is a type of life preserver that I would suggest using. And really the key are these straps right here on the bottom. So what happens sometimes when people fall in the water, their arms by nature tend to go up, and so the force of the water is up on this life jacket. If their arms are straight up, this life jacket can actually slip right off the top of their head. What these do is they prevent that from happening. So the life jacket then is pretty much fixed on the body. So these can be life-saving straps, and I tell people that as far as I'm concerned, if you're going to use this type of a life jacket, if you're not going to have these on the bottom, particularly special needs individuals or people who can't swim in general, it's pretty much useless to use another one for a long-term need in the water. Maybe if you can pick them out right away, a regular life jacket would be okay, but I certainly wouldn't suggest anything unless it has these straps right here. So worst case scenario, if a drowning incident occurs, now what are you going to do? The first thing is to carefully remove the individual from the water. We see a lot of associated neck injuries and head injuries because people fall or dive into pools or lakes or whatever, and they hit their head or they break their neck. So what we want to do is be really, really careful because of the associated injuries. So we need to get them out of the water, but when we do so, we need to be careful in doing that. Immediately begin CPR. So just a minute of my own soapbox. I think everybody who's hearing this lecture, anyone in general who cares for pretty much anybody, but particularly special needs individuals, should be basic life support trained. It's done by the American Heart Association. It's inexpensive, it's quick, it's easy, and it truly can be a life-saving thing. And just my own opinion is that all of us, particularly if you're listening to this lecture, obviously have some interest. You should be what we call BLS, or basic life support trained. So you're going to start CPR right away, and you're going to call 911 right away. We tell people not to give up because drownings are kind of an interesting type of emergency where usually the water is cold, and people might say, well, the water, like where I live, for instance, Lake Michigan, might be 65 or 70 degrees and doesn't really feel that cold in the summertime, but when body temperature is 98.6 degrees, 70-degree water is, 20-plus degrees below normal body temperature. So that has a distinct effect on the body's physiologic responses to things. And so don't stop your CPR. Continue with your treatment the best that you can until the paramedics arrive and get them to the ER, and we'll take everything from there. So for gastrointestinal considerations, the first one we'll talk about is choking. Many of our individuals have mouthing behaviors. They like to chew on things or put things into their mouth more than even what a typical child would do. Some of them have oral weakness, maybe even incoordination or both, which provides a unique risk in and of itself. And all this leads to an increased risk of choking. So once again, prevention is the key. Avoiding round things like grapes or hot dogs is really important. Hot dogs are actually the most commonly food item that's choked on every single year. So if your individual really, really likes hot dogs, that's perfectly fine. You can cut them into slices and then cut those slices in half so they're not round, and then they can eat those. Usually that's very well tolerated, and the risk of choking on that's no more than any other food. A really important one is diet modifications like thickened liquids. Some of you might read this and say, I have no idea what that means, and that's okay. This isn't meant for you then, but some of you are going to know exactly what I'm talking about. And if you do, this seems like another obvious one. If my child needs thickened liquids, then we need to give them thickened liquids. But I can tell you every single year I have multiple cases where there's been a birthday party or it's Christmas or Thanksgiving or whatever, and some individuals wanted their loved one to experience it in the same way that we experience it as typical individuals. And they give them things that are off their diet, which results in aspiration, which results in pneumonia. And then that obviously has really poor health effects for the individual that was fed foods or liquids that they shouldn't have had. And so I know it feels bad to withhold those things, but sometimes it's really the most important thing that you can do for an individual. And then obviously be careful of toys and objects that an individual might come into contact with. I tell people that with my son, despite a physical and cognitive impairment, somehow I swear that boy can take any toy apart and find the lowest common denominator, which is a tiny little round piece, and get it into his mouth. So it's impossible to watch our kids all the time, but just try to do your best. I know as a parent that's really difficult to do, but we got to just do our best to be cognizant of that. So if someone is choking, then the treatment is the Heimlich maneuver. And this is, once again, one of those things that they would teach you in the basic life support course, so we obviously can't go over all of that right now, but I found this picture which kind of gives you the gist of the three different ones. And what I don't want you to think is if you've never had BLS, you can't do something like the Heimlich maneuver or something like CPR on somebody, because the alternative if someone's choking to death is that they die, or if they need CPR, they're going to die. So I want you to feel okay with doing it. The preference, of course, is going to be BLS certified because you're actually going to learn the real proper technique. You're going to have a chance to do it. You're going to learn, most importantly, when to do it and when not to do it. But this is usually the way that we start right here. Somebody is able to stand or they're standing and they're choking. As you put your hands basically kind of in the area between their belly button and their rib cage, you're going to push up on an angle like this. The diaphragm sits right here. That's the muscle that we use to breathe. And really all you're trying to do is force that up, to force the air at a high rate of speed up and out so that whatever's blocking off the windpipe just gets forcibly expelled from the mouth. In our population, some people are confined to a wheelchair, and so you can do the exact same thing from the seated position. Obviously, you're not going to be able to do it a whole lot just because of the positioning that you need. Oftentimes you have to be pretty strong in order to accomplish this, but it is perfectly reasonable to do it in a seated position. If the individual loses consciousness, then the next step is to lay them on the ground, and then you switch to abdominal thrusts. So that's sort of the different ways that you can accomplish this Heimlich maneuver. Once again, I strongly suggest a basic life support course for everyone. Another GI complication that is very, very common in our population of Angelman syndrome, obviously, is constipation. Some individuals, for instance, Noah is not affected with this at all, but some people are really, really severely affected with constipation. Constipation really is rarely a medical emergency, and I'm not talking about bowel obstructions. That's obviously always a medical emergency. I'm talking about just constipation at this point. we get a fair amount of complaints in the ER because people come in with constipation and they say, okay, you treated me, but I could have done that at home. Everything you treated me with is over the counter, and that's absolutely true. In almost all cases, what we have to use in the ER is available over the counter, so enema, stool softeners, all of those things are readily available either in your doctor's office or over the counter. The one notable exception to that is if your individual suffers from a lot of pain and they're on narcotics, that obviously causes constipation. There's a shot of a medication you cannot get over the counter that we can administer in the ER for constipation. But if you should come to the ER, it's perfectly fine that you do. Just understand that probably what we're going to do is all stuff that they have at home. And I tell people not everybody is medically inclined. They don't want to treat their loved one with an enema or something like that. It's perfectly reasonable. That's what we're there for in the ER. Just don't be surprised if everything that we use is pretty much everything that you can get over the counter. I tell people, in general, Miralax is a good first choice. Once again, I have no idea what drug company makes Miralax. I don't own stock in it that I'm aware of. But the reason I like it is a couple of reasons. Number one is they say it's tasteless. I've never actually tried it. But it's a powder, so you can put it in a liquid. You can sprinkle it on food. Maybe even more importantly, it's what we call a non-stimulant laxative. So if you use things like X-Lax, it actually causes your bowels to spasm, which can be very, very painful. And they also cause bloating, which can be painful. When you get spasm on top of bloating, that is really exceptionally painful. And the nice part is Miralax doesn't cause either one of those. A third good reason that I like Miralax is because you can easily adjust the dose. Most oftentimes you'll start with a capful or maybe a half a capful. And if the bowel movements are too loose, you use less. If they're still too firm, you use more. There are really very few side effects to Miralax other than oftentimes the stool getting a little too loose, at which point you just cut the dose back. There are literally dozens of choices for treatment of constipation that you can try. Miralax is just simply the one that I usually use first, and those are the reasons that I try that. If the extent of things aren't working, you're still not happy with the bowel regimen, you can see your doctor. And oftentimes it does take months in order to get a bowel regimen sort of perfected, and you're going to become an expert in the bowel movements of your individual with Angelman syndrome. And a lot of times you'll know more about it than any doctor will as far as, you know, if they eat specific foods, what they're going to need or what they're not going to need. Like I said, we're happy to see this in the ER. It's just we're probably not going to use a whole lot of things that are different than what you can get at home. But if it's a Saturday and your doctor's not open and you live in an area with no urgent care, then the only place that's open is the ER. And like I said, don't feel bad about coming in for things like this. So trauma is an important one. Once again, we have many risk factors specific to our population, like hyperkinetic movements, difficulty with coordination. Some individuals have some degree of generalized or even unilateral, which means weakness on one side or the other. And what I tell people is, as either parents or caregivers of individuals with Angelman syndrome, the best idea is to learn to do a mini physical examination. And basically, I want you to know your child or your loved one up and down. I want you to know them better than what anybody knows. I can think of, within the last couple of years, 2 specific instances of special needs individuals that were brought into my ER, and the parent and caregiver told me, when I asked them what's going on, their give or take exact words are, "You're the doctor, figure it out." And I can tell you that is a really hideous way to approach the ER, because it's really not going to be good for medical care for your child, because you're going to know them a lot better than what any of us, even as medical professionals, are going to know them. So if you could say, listen, I understand that their gait, and gait's the medical word for walking, is typically abnormal, but what you're seeing as far as their walking is concerned, that's normal. Or they're favoring their left leg, that's abnormal. That gives me a lot of information, because I'm not going to know whether that's normal walking for your individual or not. And so if you can say, yeah, they're favoring the left leg, then we really can kind of know where to zero in our physical exam, because obviously we can't CAT scan or X-ray top to bottom. We really have to try to focus it in. And so if you can say, yeah, that red spot on the middle part of their ankle, that's new, or no, they always have that, that's not from an injury, that's really beneficial to us as ER staff, because we can do a more appropriate job of working your individual up based on basically the physical exam that you did, based off the knowledge that you have of what is normal and abnormal for them just on a regular day-to-day basis. And obviously you can tip us off to abnormalities that we may or may not see. We might see something that we think is normal, it's actually abnormal. And if you can tell us that, then that's really beneficial. Really what I want to talk about in specific to trauma is head trauma. And part of the reason is because we see a lot of it. Injuries in general, not just head traumas, but injuries are the leading cause of death in individuals under the age of 45. And it does not matter. That's just injuries of all people, typical and special needs. of those individuals that die, a full 1/3 are from brain injury. So there's a lot of mortality, which is the death. There's also morbidity, which is the disabling outcome as a result of injuries from head trauma. So what we do usually in the ER is we try to risk stratify people. So low-risk individuals are someone who fell, they hit their head, there was no loss of consciousness, they immediately cried or sat up, or they were always awake, they never passed out, there's no vomiting. If they're able to communicate whether they have a headache or not, they don't communicate that there's a headache, but pretty much for the most part, you say, this individual is at their baseline, this is what they're always like, and there's really nothing wrong with them. These individuals rarely need to come to the ER. That's pretty much just straightforward. They hit their head, not a big deal. If you want to see your family doctor, that's fine. If you want to go to an urgent care, that's fine. If you're uncomfortable for a reason, the ER is the only place that's open. That's reasonable, but we're not going to do a whole lot for it. These people, there's really not a whole lot of indication for CAT scanning, for blood work, for anything. We'll skip down next to the high-risk population. And this one's pretty obvious as far as what high-risk people are. And we define in medicine as if they've got 2 or more symptoms. So let's say they had loss of consciousness and they're vomiting, or they've got an obvious fracture, or they've got a neurological deficit, that being maybe a pupil is bigger or smaller on one side, or maybe they're not moving one side of their body or the other, something that is obviously abnormal. There's no question those need to come to the ER, and the truth of the matter is oftentimes you should probably be calling an ambulance to get them to us sooner rather than later. So high risk, multiple symptoms or fractures, neurological deficits, straight to the ER. Really the difficult population are the people who are in the middle, and that's the moderate risk. And these are people who usually have one symptom where they have a loss of consciousness. If they're able to communicate, they've got some sort of amnesia. Maybe they had 1 or 2 bouts of vomiting, but otherwise kind of come back to their baseline. So they're not totally low risk, but they're clearly not high risk. Those are the tough ones. And what I usually say for typical individuals is perfectly reasonable just to see a family doctor or go to an urgent care. And our population specific to Angelman syndrome, because of the difficulty with communication, oftentimes having individuals with a seizure disorder as a part of their syndrome, I err more toward the side of the ER. And when you get there, if everything is fine, oftentimes what I'll do is I'll tell parents or caregivers, we're not going to do anything for them. We'll hook them up to a monitor, and we're just going to monitor them for a few hours in the ER. And if they remain fine and they're eating and life is normal, then great, we send you home. And a lot of people say, well, why come to the ER then? And the short answer is because I've got you right there and we've got you under observation. And if something changes, let's say now they start having repetitive vomiting or mental status changes suddenly, the CAT scanner is a few steps away, and we can put them to the CAT scanner, and we have a neurosurgeon on call who can take care of a problem if it occurs. And so I usually tell people, specific to our population, if you feel that you're in that moderate risk category, I would suggest coming into the ER, and I'll feel completely comfortable with not doing a CAT scan or anything else, but just having that observation I think is a really beneficial thing. So the next thing we'll talk about is toxicology. And this little cartoon is obviously from a restaurant and kind of well-timed for us in the town just to our south. Now, I don't work there, but there was a big outbreak of the norovirus at a couple of restaurants there, and my brother actually owns a restaurant in the next town over. Unfortunately, he did not have any problems with this, but we'll talk a little bit about toxicology. So 1-800-222-1222. If you're listening from the United States, no matter where you are, that is the number for your closest poison center. It's not a mistake that I put that up there 3 times. It's really important with toxicologic exposures or potential toxicologic exposures that you call that number. And there's really a couple of reasons for that. The first reason is oftentimes you don't need to come to the ER at all. You may need to see your pediatrician or your family doctor. You'll call the poison center and they'll say, oh, no, you can drink a gallon of that and it's not going to cause any problems, in which case you know, okay, I can stay home. Or they might say, that's a little bit concerning, but all you really need to do is drink, 2 glasses of water, some milk or something like that, and things will be fine, which once again, that's great. You can treat it at home, but you don't actually have to come in to have a visit with us in the ER. Perhaps an even more important reason is they may say, oh, yeah, that's actually a really big deal, and you need to go directly to the ER, at which time you'll either call the ambulance to be brought in, or you'll start en route yourself to bring them to the ER, whatever they direct you to do. But the reason I think it's even more important is because sometimes individuals will get into a substance that's relatively rare. It's not something that we see in the ER frequently at all. And what the Tox Center will actually do is they will call me as an ER doctor, and they will say, hey, I have Joe Smith. He's on his way. This is what he ingested, and I am faxing you right now this specific treatment for that. So by the time you get to the ER, I've already called the pharmacist to get the rare drug that's needed to treat it mixed up. It's at the nurses know what's coming. We know exactly what labs we have to order, and we know exactly which toxicologic center that we're going to ultimately have to transfer them to, which makes the time to care significantly shorter if you utilize the poison center. If you don't utilize it and you come to the ER, that's fine. I'm just going to call them, and I'm going to get that direction, and it's just going to eat up 15 or 30 minutes of time while we're getting all of that done. And so you can really expedite things significantly by utilizing a poison center. I actually rotated at the Detroit Medical Center when I was a resident, and they're experts at this stuff. They've got a really sophisticated electronic database where they can look things up. If it's a cleaner, for instance, they can look up the exact brand and type of cleaner, find out exactly what's in it, what they need to do about it, whether it's an acid or base, and how we're going to treat it. So it's really an important thing to utilize. And I can tell you, just in general, it's way, way underutilized, at least in our area. This is an interesting thing. I remember when I was a kid, I brought home a whole bunch of these stickers because somebody from the Poison Center came and dropped these off to us. And I loved it. I'm the oldest of 3 kids, and I remember bringing them home and telling my mom I want to stick them on all the bottles, and that's what we always did. But what they found out is that kids are actually attracted to these stickers, and so when they started giving these out, the amount of toxic exposures actually increased because kids would see these, they'd like the sticker, they'd find the bottle, they'd be like, oh, I'm going to drink this or I'm going to eat this now. And so they would do that. So if you see these left over in your house, they've not been given out for a number of years, but if you do see one, throw it out, buy a new bottle of whatever cleaner it is. Because it's just going to increase the risk of exposure. This is another thing in regards to toxicology. If you ever see this in your house, if you've got it in your house, throw it away. It's called syrup of Ipecac, and you've probably been told by your grandma or somebody like that that there's ever an exposure, or you're concerned about something, that you should take this because it'll make you throw it up. And 3, 4, 5, 6 decades ago, that was how they treated things. The medical evidence is abundantly clear that this has no place in treatment of pretty much anything. And if you think about it, it's pretty obvious in retrospect. If you swallow something that's caustic, that's going to burn going down, whether that's an acid or a base or anything else, if you throw it up, not only are you throwing up whatever burned going down, but now you got your stomach acid coming up with it. And all of you have vomited at some point in your life, and you know if you have a lot of vomiting, which just causes a lot of vomiting, you aspirate some of this, and then you start coughing, and so then you're going to burn the bronchial tubes, you're going to burn the lungs and everything else, and so this is actually a terrible thing. I can almost guarantee you if you've got a grandma's house, if she's elderly, there's probably a bottle of this in it. It's actually probably in a glass bottle. I know this one here in this picture is plastic, but they used to come in glass bottles. When she's out folding laundry off the clothesline or something like that, find it and throw it away, because the worst thing that could happen is if she ended up giving it to your individual with Angelman syndrome, because it's really not something that should be used in anybody's special needs or otherwise. And then we'll conclude with basically just a brief overall discussion of fever. And simply I want to include this because we see a lot of fever, obviously, in the ER. So the first thing I want to kind of go over is a definition of what a fever actually is, because I get a lot of people coming in saying, oh, well, this individual has a fever, their temperature is 99.4. Well, a fever actually, by definition, is 100.4 degrees Fahrenheit or 38 degrees Celsius. If anyone's listening to this from overseas, it uses Celsius. So a temperature of 99.4 is actually closer to a normal temperature than closer to a fever. So it kind of helps just if you know what a fever by definition actually is. The reason for that is our body temperatures fluctuate normally during the day. Everybody's do. So sometimes it's going to be a little bit higher, sometimes it's going to be a little bit lower. And so you kind of got to have to set a standard number of definition as far as what really is a fever and how high can just be a normal fluctuation or variance of the body temperature. One thing that I always like to talk with people about is if you have a happy individual or a happy kid, they're playing, they're eating, life is normal, you feel them, they're kind of warm, you take their temperature, let's say it's 101. When that happens in my family, and what I suggest to people is leave it alone. In fact, if my kids are acting normally and they feel warm to me, I don't even take their temperature because I'm not going to do anything about it. They may have been exposed to something at school and their body's fighting it off. A fever is a normal response to that. And if they're happy and they're not sick, I'm not going to do anything about it because nothing needs to be done. If they wake up the next morning and they're fine, then great. It was a transient fever, just a temporary fever for whatever reason, and it's gone. Conversely, oftentimes you'll see kids that look sick. They look absolutely miserable, or even an adult individual who has difficulty communicating. You just look at them and you say, boy, they look miserable. Their nose is running and they've got a cough, but there's no fever. It's perfectly reasonable to treat them with some Tylenol or Motrin simply because they've got body aches and they feel miserable. So I tell people it's more important to treat the person than it is to treat a specific number, because people really get caught up in the number of a fever. A fever of 102, 103 is not going to hurt anybody. It's not going to fry the brain. It's not going to cause any long-term damage. Obviously, if the fever is 107, 108, that's a different story, and we rarely see that. In fact, the majority of the time that we see that as a result of head trauma because you lose the ability to auto-regulate temperature. So if it's an overall healthy person who's just sick, you almost never get a fever that high. So my own, I guess, view of this, maybe a little bit sarcastic, is that I think Tylenol created this fear of fever that we have in our society. If you think about it, whether you believe in creation or evolution, humans have been on the earth for at least 5,000 years, maybe millions of years. And so you've got all these people who lived for a really long period of time with absolutely no way to treat a fever. And clearly we did quite well just as a species with no way to treat fever until all of a sudden we've got Tylenol, and now there's a fear of fever. So fevers are physiologic. They actually do serve a purpose, and they're not something we need to be overly scared about. So what I usually tell people is if your child or your individual is getting sick and they've got a fever, it's perfectly reasonable to treat the fever. We frequently get people in the ER who've had a fever for 30 minutes or for 40 minutes. And their exam is completely normal. That's all they have is a fever, and it's because they came in so early in the course of the illness. If there's a pneumonia, we're not going to see it on chest X-ray for a while. It's going to take a while before an ear infection actually shows up to the point that I can see it with an otoscope. You know, they might not have developed a runny nose and a cough, kind of like what I have now, just because they're not really that sick yet. And so when you get a fever, it's not really a fever in and of itself in an otherwise healthy person, which many of our kids with Angelman syndrome are perfectly healthy, to come in right away to the ER just because they have a fever. If there's something else going on, they're on chemotherapy because of a cancer, or they're on immune modulating drugs, if you know what that means, you know what I'm talking about. Those individuals have immune suppression, and fever in and of itself is an indication to go to the ER for those people. But in general, a fever is not something you have to get overly worked up about, overly worried about. If a fever persists for more than 24 hours and they're just in general sick, it's perfectly reasonable to see your family doctor for evaluation of that. But usually we like to at least give it a day simply because we would like the symptoms to start so that we can actually give you a diagnosis as to maybe why the fever is there. Because if there's a viral upper respiratory tract infection, you don't want to give antibiotics because you can increase the risk of C. diff or other infections like that as a result of the antibiotics. But if they got an ear infection or a urinary tract infection or something like that, then clearly there's an indication for treatment. And fever is also one I quite frequently get questions about, especially from people who disagree with my general persuasion towards treatment or approach to fevers, and that's fine. So if there's questions, like I said, feel free to submit them, and we can answer them here shortly. So one thing before we field the questions, I'd just like to remind everybody to register for the walk. Tomorrow's actually our deadline to register and raise $25 to get the T-shirt and the goodie bag. So if anyone out there listening hasn't done that yet, or you have friends who you know are going to come but haven't done that yet, I just wanted to remind everybody to do that. I'd like to thank the Angelman Syndrome Foundation for putting this lecture series together. Hopefully you guys are finding all of these lectures at least somewhat beneficial. As an aside to that, I would love feedback on my lecture, but really on all of these lectures, because the only way that we can improve them is by getting feedback. So if you say, you know what, that Justin Girl guy was the most boring lecture we've ever heard and there's nothing I got out of that, that's fine with me. Let us know and we can cancel the lecture. I'm not getting paid for it, so there's really no benefit that I'm getting directly from doing it, or anyone else for that matter. They're all volunteers, and we'd all be happy to change our content. If you say overall it's great, but we would like more of this, we'd like less of that, that's fine too. We can change it. If you don't like this platform, maybe we could try to change it, although I think that so far it's been pretty good, at least from my experience. And if you ever need to contact me, if you go to the Angelman Syndrome Foundation website, on that top little bar of links, the one all the way over to the right, If you click on that, you will see a link to the board of directors. And if you click that, when you go down, you'll see a picture of my family and I. And my personal email is on there. That's not my work email. It's my personal email. So I check it even from home. I'd be happy to get questions from people if you just have questions in general, whether they're medical or just, hey, I have a child with Angelman syndrome too, and I don't know many people who have it, and I heard your talk, and I'd really like to talk to you. I'd love to talk with you about that. I'll respond by email, or I can give you a call if you give me your phone number. If you have anything as far as the foundation is concerned, since I'm a board member, that you would like to see us do or like to see us change, but you don't feel comfortable calling the office, feel free to email me, and I can bring that up in an anonymous way to the board. So I'm more than happy to facilitate any of that kind of stuff, because really, as a member of the board of directors of the foundation, we're trying to do things to the direct benefit of our community. And the only way we can improve is to get feedback from you guys. And so whether it's about this lecture, any of the lectures, or just things in general, please do feel free to contact us. Or like I said, if you don't want to directly contact the foundation, feel free to email me, and I can contact them on your behalf in an anonymous manner. So with that in mind, I'll be happy to field any questions that you might have.
I actually do have a couple questions that came through, but in the interest of time, we'll just do one for now, and then I can send you the rest. The one that I have is about sedation or conscious sedation in the ER for procedures such as stitches or setting fractures. Any recommendations for that? The story, the background is they've had challenges getting the ER physician to give enough to knock out their daughter so that they can effectively suture or completely examine her. Typically, they want to give a little amount, which just makes her angry and on the edge. So any thoughts or recommendations to that?
So this is a difficult one for you as a patient or a parent of or caretaker of an individual, whether they're a child or an adult or child with Angelman syndrome, could be a typical child for that matter. I am a big fan of moderate sedation for painful procedures for kids or special needs individuals. The reason being is that it's miserable. For all of us who are listening to this lecture, we can rationalize why it's necessary to get a numbing shot, but for kids or special needs individuals, that's just not going to occur. Not everyone agrees with me, and some people aren't comfortable with doing moderate sedation, especially if you're in a community hospital, because maybe they trained in a place that wasn't really high acuity with these procedures, and there are risks associated with moderate sedation, and they're not insignificant. It would be my hope that every ER should be well-staffed with somebody who is perfectly capable of doing moderate sedation. Ultimately, the difficulty that we have as patients when this occurs is that if the physician absolutely refuses to do it and they're the only one that's there, we have no choice as a patient, because they're simply not going to order it. If they don't order it, we're not going to get it. I think that that's completely inappropriate, to be perfectly honest. Your only recourse at that point, honestly, would be an after-the-fact type of deal, and basically contacting the hospital and saying, you know, I believe that my child was treated inappropriately, and here is why. I think it's a perfectly reasonable thing to do is to mention to the doctor, you know, I know you're probably not used to dealing with children or adults that have Angelman syndrome. This might be the only kid with Angelman syndrome or adult Angelman syndrome they would ever see in their entire career. I've actually seen a couple of them within the last year in the ER, which is really, really rare. Made my day each time, but one way or the other, we'll just say they have difficulties with this. They're not going to understand it. They're going to fight it, and oftentimes have superhuman strength, at least if they're like my son. And it would really work better to use sedation. Now, there are some medications we use for sedation that will increase the seizure threshold and some that decrease the seizure threshold. And so it will be important for the doctor to know whether the seizures are well controlled or not, because if you say, hey, the seizures are really not well controlled right now, it really might not be a good idea to do a full moderate sedation and just do light sedation. But if seizures are perfectly well controlled, there's not been a seizure for 6 months or a year, there really shouldn't be a contraindication to moderate sedation, because now you've got somebody with Angelman syndrome, but that'd be no different than doing a moderate sedation on somebody with well-controlled epilepsy who is otherwise a typical individual. So it might be a little bit, when I was talking about being an expert in Angelman syndrome, this is one of those areas where it might help to say, just help the doctor realize, just because they have Angelman syndrome, it really doesn't change the majority of their physiology to a significant degree, as far as, you know, they can be sedated just like anyone else can be sedated. And if their seizures are well controlled, that's great, and we're going to keep them monitored anyway. and I understand that there might be a risk of a seizure as a result of doing it. But as a parent or as a caregiver, I'm okay with that risk because I don't want them to be miserable for the next 2 hours while we try to set this fracture or reduce a dislocation or do a complicated laceration. So it might take some of your time, it might take some of the doctor's time, but I guess the way that I would approach it is just trying to educate them on why it is perfectly appropriate to do a moderate sedation on an individual with Angelman syndrome. And Sheila, I have time. I'm happy to answer more questions. If you really do want to keep it to an hour, I can email out answers. But if you want to do more, I can answer more questions.
Okay, we can do one more if you want.
Okay.
It's in regard to the use of restraints or soft restraints for procedures, pros versus cons. They feel that their daughter has a much better exam and she feels more comfortable if she's swaddled or papoosed. So any thoughts on that?
Yeah, I've got a couple of thoughts on that. Number one is hard restraints in general. I'm not a favor of. Soft restraints are fine. So papoosing is okay. What I prefer to do, and people, and we'll touch a little bit on that moderate sedation question with this too. So let's say you have a physician who absolutely will not moderately sedate the individual. What you can do is do light sedation with something like a papoose, or if they're an older individual who can't be papoosed, you can just kind of roll them in a sheet. And we'll do that frequently if somebody doesn't want moderate sedation for their individual. I've done this many times where we'll give them light sedation and then roll them in a sheet. So the light sedation kind of just calms them down a little bit, and then we can restrain them in order to do the procedure. Some people on its face see that as very restrictive, which it is for a temporary period of time. I'm not going to lie, you're going to roll somebody in a sheet. But the truth of the matter is if you have a difficult procedure to do and you want it done right, which of course all of us want us to do, sometimes this really is the best choice. You can do moderate sedation and then you don't need any sort of restraint, but if you have a really complicated laceration that's going to take maybe 45 minutes or an hour to repair, you can't moderately sedate someone for that long. That does not work. So at that point, you really have to do light sedation, and if they're not going to hold still, you're never going to get a good repair of that laceration. If they're going to be rolling around, they're going to get contamination in there. It's going to become dirty. It's going to increase the risk of infection. So it's actually the best thing for the patient oftentimes to have some sort of restraint. And this is with typical children, just like it is with special needs individuals of any age. Sometimes restraints are the best thing for them because it's the safest thing for them for that very short period of time. If they use a restraint other than something like a papoose or a sheet, and they just use like a soft restraint to keep 3 extremities down while you're working on another one, those restraints should be removed as soon as possible. So when the procedure's over, everything's fine, everyone's calmed down, those restraint should come off. If the person's a little bit combative as a result of it, what we'll usually do is start with one restraint off, because a lot of times that helps them feel a little bit less restricted. They calm down a little more, you can take the third restraint off. Calm down a little bit more, you can take the last restraint off. But it's something that you have to use judiciously and for a minimal amount of time. But the honest truth is in the ER, you should feel perfectly comfortable if you feel that a restraint for your individual is the best idea. With light sedation, that is a perfectly reasonable decision.
All right. Well, we do have some other questions. I can email those to you after, and if you could just answer them, then I'll send them out to everybody who was on the call today. We appreciate you all taking your time and being with us today. And Dr. Grill, we appreciate you taking time out of your day to be on this call with us today. Just a little reminder, and we'll put this up on our website, but the next webinar that we're going to be hosting is on May 29th at 6 o'clock Central Time p.m., and that's with Dr. Bodette. So if anybody else has any other questions that they think of afterwards, obviously you can email Dr. Grill or you can email us at the foundation, and we'll get back to you. Thank you.
Thank you, everybody.